Good afternoon, everyone, and thank you so much for joining the Kentucky Statewide Opioid Stewardship Program webinar today. I'm Marilyn Connors, a physician consultant and family practitioner physician for about 30 years. I'm joined by my colleague Shanna Jaggers, who is a primary care pharmacy consultant for the KYSOS program. And for those of you who don't know what all that acronym stands for, it is the Kentucky Statewide Opioid Stewardship Program, the first one in the state of Kentucky, and actually the first one in the nation. So we're very, very proud of that. We are sponsored by KHA, and KYSOS works with hospital-owned primary care clinics to implement safer and more consistent opioid management for patients on long-term opioid therapy. Before I introduce our speaker today, I just want to take a few minutes to do a little housekeeping items. This webinar is being recorded and will be posted to the KYSOS webinar website in about a week. For attendance purposes, if you would please type your name, profession, and title in where you work in the chat box. And please, if you could, mute your lines throughout the presentation. After the presentation, there'll be time for questions and comments. And at that time, you can unmute your line or you can type your question in the chat box and we'll read it out for you. The title of the presentation today is Kratom, Clinical Implications and Emerging Trends. And it is going to be presented by Julia Martin, who is a physician, professor of emergency medicine at University of Kentucky, and co-investigator on the Kentucky OD2A, which is Overdose to Action. And now I'd like to turn it over to you, Dr. Martin, and you can start whenever you like.
Very good. Well, thank you for having me, and I hope you all will find this information useful. So I think the first thing we do is talk about disclosures, and I don't have anything to disclose. I have no financial benefit from giving this talk, and this presentation is the work of myself. By using some resources and stuff. The first thing is to go over how to pronounce it. Is it Kratom or is it Kratom? Both are acceptable. In the US, most people are using Kratom, but Kratom tends to be closer to the native pronunciation, and so it's also equally used as well. So either Kratom or Kratom is appropriate. The scientific name is pronounced mitrogen. So you get a lot of those questions of, is it Kratom or Kratom? So what is the history of Kratom? It comes from the leaves of a South Asian plant, and traditionally it is chewed by the native people. They use it a lot to treat for pain, anxiety, and to give them energy. They either chew it fresh or they dry it, drink it in teas, and less common smoke it, but there is some smoking of it as well. It's the newer shifts that we're seeing to the more high potency alkaloid extracts that are causing a lot of alarms that are going off, and the increase in use that we're seeing. And we'll get into a little bit more of why that is and why it's concerning. So what is it? Why are people using it? It contains a psychoactive compound that will attach to the opioid receptors. It's structurally different than most traditional opioids, but it still binds to the mu receptor. It binds weaker than morphine, but it can still give the similar effects, and that's why some are using it for pain and some are using it for the withdrawal symptoms. It also can bind to the delta opioid, the serotonergic, and the noradrenergic receptors as well, which gives it the properties of the antidepressant and mood-altering effects that a lot of people are using it for as well. It is then can be oxidized into the alkaloid 7-hydroxymitrogene, which has the stronger binding towards the opioid receptors, and you'll see the full opioid effects similar to morphine, but this is a small amount of the native mitrogene that converts to the 7-OH. It is also widely available in gas stations. You can't drive down a street and not see the signs for Kratom and the advertisements. You can also buy it online. So it's easy access, easy to get, and which leads to the use and abuse. So again, we talked about how it's used. Traditionally, the locals would chew the leaves or they dry them to smoke them or brew them as a tea. Now the popularity's increased, so they make it easier. Initially, what you were seeing were capsules made from the dried leaves sold in the gas stations, powders that you could use to mix into drinks, liquid extracts, and now they're marketing with gummies and energy shots with all kinds of really creative, fun-looking packaging. The 7-hydroxy or the 7-OH is now hitting the market, and it's a more concentrated product and has much more profound opioid effects. It's the one that will bind stronger to the opioid receptors and thus increases the potential for abuse and addiction. And that's where a lot of the focus has been on trying to stop this product. The flooding of the market of this product also coincides with what we saw in 2025 for a significant increase in use, overdosages, and deaths related to mitragine. Again, it comes in all kinds of fancy different packaging, quick tablets, drinkable liquids. Even it looks like some of your normal drink mix that you add to water that you can carry with you. So the dose, again, it's not FDA approved, it's not regulated, there's no standard dosing. It can be contaminated, so you never know exactly how much you're getting in the product that you're buying. But if you research online, the recommendations are anywhere from 1 to 4 grams if you just want some extra energy, feel alert. Greater than that, greater than 5 grams, you'll start to see some increase in the opioid-like effects. And some of them are recommending 5 grams up to 3 times a day to get the truly opioid type effects. It appears that the onset of action is between 5 and 10 minutes after drinking the tea and can last about an hour, and that's related to traditional preparations. The pharmacokinetics, it undergoes hepatic metabolism. And that's where some of it can convert into the 7-OH. Again, it's usually just a very small part of mitragine that gets converted to the more powerful 7-OH. And then it's ultimately excreted into the urine. The half-life, if it's pure mitragine, is about 3.5 hours. The 7-OH tends to clear a little bit faster at 2.5 hours, and the terminal half-life is about 23 hours after an oral ingestion. You can hit a steady state in the blood in about 7 to 9 days after continued use. So what does an intoxication look like? The U.S. Poison Center did a study, and they asked patients who used Kratom what were the type of effects that they were seeing. Most of it is agitation and irritability. You'll see predominantly tachycardia more so than than bradycardia. Then you get a lot of the GI stuff, abdominal pain, nausea, vomiting, drowsiness, lethargy, confusion comes in. Less common is seizures, but it's well documented. And then with more chronic use is where you'll see the hallucinations come in. Most of the clinical effects wear off in less than 8 hours, but some can last up to 24 hours. It depends on whether it's acute versus chronic users, and how much is built up into their system. But 8 hours, most of them should be clearing by then. Systemic effects, it can cause some respiratory depression, even cyanosis and apnea. Tachycardia is the most common cardiovascular side effect you'll see, which will drive up the heart rate, can, like most stimulants, can end up progressing into some heart failure. There is documented increased risk of ventricular dysrhythmias. A lot of the deaths related to mitragine is felt to be related to acute ventricular arrhythmia. Hepatotoxicity is well known as well. It's considered a reversible liver injury. It starts within several weeks of the use, presents like typical liver failure will. They'll be fatigued. They'll mention dark urine and jaundice. What you'll see laboratory-wise, you'll see an increase in the alk phos and bili, but the AST, ALT often are normal or just mildly elevated. If they stop using kratom, the symptoms improve. The liver function test also improve. But if they start using kratom again, the hepatic toxicity comes back. So this is one, particularly in the young people that come in with liver failure and not knowing what it is, to be sure to ask them if they're using kratom. Seizures, there's multiple case reports. It's not well understood the mechanism why kratom would cause the seizures. It's often more seen in polysubstance use. It also is seen in people with known seizures, predominantly lowering their seizure threshold. And those that don't have a history of seizures, they found about 1 in 3 will have some kind of underlying abnormal EEG and probably predisposed to seizures to begin with. They also found co-ingestions with methamphetamines and Benadryl increases the risk for seizure activity with kratom. And then mental status changes. Agitation and irritability is probably the bigger things that you'll see, but you can also see the lethargy, sedation, and coma, particularly in the co-ingestions. There have been reports of press in some of these patients, so keep that in mind. If they're not clearing like they should, you might consider getting the MRI to look for press, particularly if they've, have the elevated high blood pressure as well. The treatment of acute intoxication is really symptomatic care. If they're extremely agitated, you may need to use some benzos and other things to calm them down. There's no role for GI decontamination because it is absorbed so quickly that the risk of aspiration with activated charcoal is too high, so no need for that. If they have blunted respiratory status, unresponsive, Narcan is appropriate. Often these are polysubstance users, and there's an increased death rate with co-ingested with opioids. So Narcan's always appropriate in these people. And even single ingestions of kratom without other opioids on do respond to Narcan. If they have seizures, benzos are still first line. Second line, however, shifts a little bit. You want to go to the phenobarbital or propofol because they work better for the toxin-induced seizures than Keppra and Dilantin. So this is one where you're thinking the overdose ingestion thing, just switch up from Keppra and Dilantin over to phenobarbital and propofol. Avoid the dexmedetomidine because it's very similar to mitragine and can exacerbate the symptoms and toxicity. Prolonged ingestions, often associated with anorexia, weight loss. They'll have depression symptoms, even though it's like a lot of these drugs. They start using kratom to help with depression, anxiety, as quoted on the internet, and then they only become more depressed. Hallucinations and psychosis, those are the two that I think I see the most of. People are bringing in a family member because now they're just kind of crazy. They've started hallucinating. They have a lot of delusions, and you find out they're chronically using kratom. The other, the anorexia, weight loss, that can be almost anything. Insomnia, depression, is it just worsening depression or are they using kratom? Those are a little bit harder to tease out, but it just reminds us to ask patients if they're using over-the-counter stuff to see how much it's weighing in. Um, so I think the things that will really pull it out in my practice is that people are presenting with hallucinations and psychosis. It is interesting because you'll see some of the people are saying it's non-addictive, it's a safe drug, it will treat this stuff. But we do know that more than 50% who regularly use it more than 6 months develop dependence to the medicine. What about withdrawals? They can have withdrawals. It's very similar to opioid withdrawals, but is often milder because it has a milder binding to that opioid. The 7-OH will have a stronger withdrawal symptoms. It will generally start 12 to 48 hours after they stop using it. Withdrawals can last up to 7 days. It is more common the more frequently they use it and the higher the doses that they use it. And this, again, 40% report that they've tried before and were unsuccessful quitting it. So it fits with the addictive properties. There are case reports of neonatal abstinence syndrome while using it while they're pregnant. So watch for opioid withdrawal sort of symptoms in infants. And even if it's negative for narcotic on the screens, it could be kratom use, particularly if they're trying to avoid opioids during pregnancy and they think kratom is safe and start using that during the pregnancy instead. The treatment of withdrawal for moderate and severe, if it's mild, you don't need to do much, maybe some antiemetics, but moderate to severe, you can offer the buprenorphine like we do opioid withdrawals, and the induction and maintenance dosages are very similar that you would do for an opioid use disorder. If they decline it, you can try the clonidine to help mitigate the symptoms of withdrawal in the severe withdrawal patient. Disposition, most patients can be discharged from the ED after an observation period of 4 to 6 hours. But those that are persistently appear intoxicated after 6 hours generally get admitted. Those are the ones that probably will need at least 24 hours to clear. Most seizure activity, they recommend admission because of the increased risk of death associated with the seizure. And that's usually because you're suspecting polypharmacy overdose. Of course, anybody that is self-harm or SI. There are a number of patients that will use kratom as their primary overdose for self-harm. Like anything that is potential abuse, those that have needed to require hospitalization or visits to the emergency department should be referred to outpatient substance use disorder treatment, and they should all go home with Narcan. We've got some Central Kentucky examples of what we've been seeing, particularly at UK, but this will illustrate some different presentations of how they come in and the thought process. This is coming from our OD2A data set. And those that may not know the overdose to action data set, what we are doing is when patients arrive to the emergency department and we're concerned that they've had an overdose, we'll identify those patients, flag them. We actually put an order into the computer, which flags Regan and the research team to review it. if there's any samples left over, it can be blood or urine or drug paraphernalia if they have that on them. The lab saves us when that order goes in. The lab will save any remnant samples. And then based on the history and how they're presenting, if anything seems off at all, we can send it for non-target analysis, send it off to the DEA, and they'll run a full mass spec on it. We had about 3,000 encounters, 460 of those were sent off, and out of those 460, 25 were identified as mitragine so far. And of the 25 patients, the average age is about 40. Most of them are male. They had a length of stay about 2 days, and 3 of them required ICU admission. You can see most of them presented either decreased level of consciousness, confusion, or agitation, and then some seizure activity were the most common sort of presentations. The first case is a 48-year-old man that was found minimally responsive at home after an overdose. He was well known to be a polysubstance abuser. He reportedly had some decelerate posturing followed by seizure activity for about 5 minutes. He was given midazolam 5 milligrams, and then still had some questionable seizures on arrival, received additional Ativan, Keppra, and was intubated. His wife says he had a history of substance abuse, and she was concerned that maybe he got into Spice or Serenity. His drugs of abuse screen had amphetamines, benzos, marijuana, and buprenorphine. His full drug screen had Keppra, which of course was given in the ER. When we sent him off for testing, and the providers on really thought he had the synthetic cannabinoid exposure, but the DEA tested showed significant kratom. So the mitragine level was extraordinarily high, as well as the 7-OH mitragine. Yohimbine can be another abused drug, but it also, the structure of yohimbine is very close to the mitragine as well. Case 2 is actually a 15-year-old, so we're seeing some pediatric cases as well. Was brought in for acute mental status changes. Grandmother's reporting that he was acting very erratic, speaking very incoherent. He was combative initially with EMS, but by the time he arrived to the emergency department, he was calm, nonverbal with dilated pupils. And EMS said he had smoked too much spice. The drugs of abuse screen was negative. We sent off the DEA testing, and the plasma was negative, but the urine was positive for psilocybin, which is the magic mushrooms, as well as 7-OH. So it was likely that he got a hold of some hallucinogenic mushrooms that was tainted with 7-OH. Case 3 is a 36-year-old man that was at work. Co-workers noticed that he was making some really strange noises, went in to check on him and found him unresponsive. He then developed some seizure activity. Co-workers couldn't feel a pulse. They got an AED, that no shock advised. CPR was started. EMS got there, they found a pulse and transported him. Upon arrival, he was awake, extremely agitated, diaphoretic, confused, grabbing at things. He was unable to be redirected at the time of arrival, so he ended up getting droperidol and Versed to calm him down. He had pulled out all his IVs, so we went IM on that. Then he slept for maybe 30 minutes to an hour, woke up and admitted to Kratom use. His Kratom use was both chronic and acute. He'd had a long-standing history of opioid use disorder and was trying to manage it himself with Kratom, but admitted to increasing stress and was taking larger amounts. His drug screen was positive for amphetamines, cannabinoids, Tylenol, and doxamine. When we sent off his testing, he had a high level of mitragine. Sorry. And as we talked about earlier, mitragine with amphetamines increases your risk significantly for seizures, and that's his presentation with seizures. And the last case is a 32-year-old history of seizures and frequent Kratom use. EMS reports complaining of a headache for several days, found down, pulseless. CPR was started, intubated. They got ROSC. She coded 2 more times, required norepi and epi drips. And again, remembering common things are common, even though you may be thinking this is a Kratom overdose. Her head scan showed diffuse subarachnoids. Several things that go into play with that is that seizures, the high blood pressure and tachycardia from Kratom use can increase the risk for subarachnoid. The DEA screen confirmed her Kratom use. So the depth of the problem is escalating pretty rapidly on us. The product has shifted from the traditional preparations and has expanded from, instead of the loose leaf and the tablets, they've now marketing with the gummies and the energy shots, things that are attracting younger kids to them. So there's a heavy marketing out there promoting Kratom. So we've seen the increase in the use of it. The products enriched with the 7-OH are so significantly more potent that it has profound opioid effects and causing an increase in hospitalization and emergency department visits. The shift in product goes along with what we're seeing in the increased toxicity and the increased use and the increase in pediatric cases. And of course, you can see the pediatric cases would be really prone to getting into some of these pretty packages and another gummy and sharing with friends sort of things. The 2024 data is very toe-telling on that. Out of all the cases, if you see the 107 occurred in those less than 5 years old. And to me, that speaks volume for this marketing technique that they have and that parents are leaving them out, because I think we all know a 5-year-old's not going in and buying them, but this is what's found in the household and this is what they're getting into. That 107 in less than a 5-year-old is far more than the 6 to 19-year-old cases. And so I think it's very evident what the marketing is doing in terms of the pediatric ingestions. Most of them are unintentional in terms of the toxicity. Some of them are taking it to get higher to treat things, but we've seen the increase in required treatment in healthcare facilities. Before, most people would stay home. We didn't see a whole lot come in with Kratom stuff. We were just finding it incidentally, or they would tell us that they're using Kratom, but it didn't have a huge impact in their care as it is now. 76 were considered major events, and there were 7 deaths in 2024 related primarily to mitragine. The CDC put out a report on Kratom-related poisonings in the end of March of this year. And it looked at 11 years between 2015 and 2025. And it's really important to see such a huge jump in 2025. went from 258 reports to Poison Control Center in 2015 to 3,434 in 2025. This large increase again coincides with the increasing formula of the 7-OH, which is more potent and powerful, which I think is what's driving the use and the marketing that's been occurring as well. There's a lot on social media about it as well. So all of that combined has increased the use tremendously. Single versus multiple exposures. Single exposure still counts for most of the reports to the Poison Control Center. It's increased 9 times from 2015, but there's also a 10 times increase in the polysubstance exposure. So it's increased for both single exposure and multiple exposures, or multiple substance exposure. So in both categories, we've seen a significant increase in the use of it. We've also seen an increase in the single substance exposures requiring hospitalization. And again, that's most likely due to the 7-OH. Multiple substance exposures have a higher incidence of a hospitalization, serious outcome, and is what's associated more with the fatalities. This, again, just shows you single versus multiple. Again, both have significantly jumped in the last 11 years. The demographics, when you look at this, they're still predominantly males that use it, whether they're doing a single ingestion or multiple ingestions. But females also saw the same rate increase over the same time period. We're still seeing predominantly white people that use Kratom, and it tends to be more middle age, the 30 to 50-year-old. This is interesting to me that 56 are employed and self-employed by 15%. So most of them are employed, and about half have private insurance, and 82% have some college experience. So 47 have some college, 25 actually have a degree, and 10% an advanced degree. And about half the households have incomes over 50,000. This is just a nice graphic that shows the significant increase. First one is your male versus female, both saw an increase. And then we see the increase in all age groups. So when they asked him about the use, 2/3 of the patients that use Kratom say they use it to help manage their depression, anxiety. Again, I think that's the internet driving that. A lot of them report self-treatment of pain and then the emotional mental conditions. It is interesting to find that 40% actually discuss their use of Kratom with their healthcare provider, which I thought was probably higher than what I would expect. But it's good to know that they are discussing it. The primary source that patients are saying they get their Kratom information from is internet searches and friends. When Kratom is related to dependency, it is more likely to occur when they were younger, self-insured, Medicaid or Medicare, or no insurance. So those are the ones that tend to really abuse it like an opioid or to replace an opioid addiction. There was a total of 233 Kratom-associated deaths reported in that 11-year time period. And those were noting that mitragine was the #1 cause of death in those patients. It accounted for 3% of all the serious medical outcomes related to Kratom ingestion, and 79% of those were multiple substances, opioid being the number one related substance in the fatalities. The impact on healthcare, as you can see, is increasing. The hospitalization rate for both single and multiple substance exposures have increased over time and particularly jumped in 2025. Some of the take-home messages is that mitragine does act on the mu opioid receptors and can lead to dependency and addiction, particularly the 7-OH, which is more potent than morphine in terms of attaching to that receptor, which is led to the increased concern in kratom and particularly the synthesized kratom, the 7-OH. The kratom use over the last 11 years has significantly increased. We saw the highest levels last year in 2025. The FDA also noted that there was a significant jump in the volume of kratom products entering into the US. And this large increase in the use also coincides with the synthetic formulation. 60% of the exposures resulted in a serious medical outcome, and about half of those required hospitalization. So it's going to have an impact on hospitalization and bed status as this addiction increases. A couple things to watch out for is krypton. They are taking powdered kratom and mixing it with the tramadol, and it increases the risk of seizures as well as serotonin syndrome. So sometimes you can end up seeing some of the symptoms of kratom, but also some serotonin syndrome, and it's resulting in multiple overdose fatalities. And then kratom mixed with anticholinergics, some of those cases that I showed you earlier, quite a few of them had the Benadryl mixed in. It increases the delirium associated with both of them. And you have your typical anticholinergic sort of presentation with those. And one last note, there has been one case report of a kratom-associated cardiac arrest that was unresponsive to most therapies. They did throw the final Hail Mary and gave him the lipid emulsion and got ROSC, but it didn't last. The ROSC didn't last, and the patient eventually died. So it's like similar to other toxic overdosages. You can give it as a last try, as a Hail Mary, but once you give it, there's no going back. And usually once you get to that point, the outcomes are poor anyway. These are the references I used for this talk, and they'll be in the slide deck for those that want to dive deeper in. I do think the CDC report was very eye-opening in terms of the jump in the use of kratom and the impact on healthcare that it's having. One final thing, if you people probably already know that the governor in Kentucky has classified the 7-OH as a Scheduled I narcotic, making it illegal to sell, possess, or distribute. Other states that have followed have been Florida, Alabama, Arkansas, and Connecticut. There are several states that have banned kratom altogether, and those are Indiana, Louisiana, Vermont, and Wisconsin. Unfortunately, I think there's some in the federal government that is pro-kratom use, so we'll see what happens in the future. But that's all I have for you all.